Hi, I'm John Carlson. I'd like to welcome you to the APA Psychotherapy video series. This series is on specific treatments for special populations, and this video is on ADHD, or Attention Deficit Hyperactivity Disorder. And our guest is Dr. Bob Resnick. Welcome, Bob.
Thanks, John.
What is ADHD?
Well, the language actually came out in 1980 with DSM-3, and it's gone through lots of changes, but now everybody's ADHD, Attention Deficit Hyperactivity Disorder. Oh. And there are three subtypes. There's the predominantly inattentive, the impulsive hyperactive, and then the combined, taking the first two into account. It's always been around. We used to call it minimal brain damage, minimal brain dysfunction, hyperkinetic syndrome. And it has maybe 3 to 4 core symptoms: inattention, impulsivity, hyperactivity, and I tack on distractibility.
Now, does it differ depending on whether you're working with children or children have these symptoms or adults?
Children can change, the symptoms can change over time. The younger the child is, the more likely you are to see the impulsive hyperactivity. But with growth and development into the teenage years, you usually see a significant reduction in the hyperactive component. And for the large number of adults who continue with symptoms, that hyperactive component is fairly benign, fairly mild, and not often seen as much as you would see it in, say, a 5 to a 10-year-old child. And
I've been reading your work, and you talk about ADHD through the lifespan.
Yes.
Yeah. And I had thought it was just for kids. Yeah.
Well, we all did for the longest time. But about 25 years ago, 28 years ago, it became really clear that they don't all outgrow it, as we used to think. Yeah. And we used to think that because that hyperactive component would diminish. And the inattention would be there, and so people wouldn't notice that as much. And now we know only about 1/3 completely maturate through the ADHD problems. 2/3 will have it as adults, but that doesn't mean that 2/3 will need active treatment.
Now, in your approach to working with people with ADHD, what are the roots of it, or the theory that you operate from?
Well, it's been called lots of things. I've called it loop closing, putting the barrel around the child, but basically it's a behavioral, cognitive learning approach to seeing where things aren't working and developing interventions that will reduce the behavioral problems from increasing and keeping the child or teen or adult from getting into difficulty.
So you're working a lot with the behavior and a lot with the thoughts?
Yes. The older the child is, the more I can do some cognitive work. The younger the child, the more I'm looking for the protective environment to make the world ADHD friendly.
And that's why you like to work with the parents when you work with the younger children?
Oh, yes, yes.
Because you're trying to change the world.
Have to educate the parents as to what this is and what it isn't, because parents oftentimes feel tremendous amounts of guilt and anger over this child who just won't mind. So the first step, of course, is to educate the parents as to what this is, and then show how they can be an ally of the child, and frankly the child with the parent, to set up contingencies, if you will, or behavioral things to reduce the errors.
Now, this may be too personal of a question, but if it is, it's okay. You can skip it. But how did you get into this work?
I have one. Our son
You have one?
is an ADHD, was an ADHD child, now he's an ADHD adult, and he was born before 1980, so we didn't know what he had. People tell us he had it, and don't worry, he would outgrow it. And I would say, well, what's the it? And they would say, you know. I said, well, no, I don't know. So he was misdiagnosed, and then when properly diagnosed, treated improperly. So the first step was to educate myself in this problem so I could help him, and then help the family. And then it just gradually grew into a greater and greater interest. And now that's all I do.
So you have it both at home and at the office all day long, huh?
Well, not anymore. He's 33, but yeah, you know, been there, done that.
Yeah. So in your approach, can you talk a little bit more about how change takes place? You know, if you're going to help move these youngsters along or these adults along, how does change happen?
It's an ongoing process. By that, I don't mean that you see kids every week for years and years and years. It's often lifetime but intermittent. People or parents will come in and say, he was doing fine, now he's in middle school, and now he's having difficulty getting his assignments. Well, in middle school, things are changing. They're changing classes, there's much more movement,
Oh, yeah.
the school doesn't follow them as well. So you troubleshoot, again, where the problems are, and set up new behavioral contingencies or some cognitive strategies to help with those particular problems. And then monitor, and then once they're set, the parents are very good about, thank you, we've got that. And then they come back. I have one adult ADHD person I've seen for 25 years, and he says, you know, I have to come back to get my batteries charged. And every time he needed them charged, it dealt with a new issue. He was changing jobs, he was getting married, he was going to have to move for a promotion.
So these normal, almost developmental transitions, you need to be there for.
If it creates the problems and the stress and the inattention and whatever's causing those difficulties, then they come back and you troubleshoot those problems.
Now, this problem is a biological problem too. So, I mean, this would really need to be a biological, psychological, and social approach.
Well, in the best of all worlds, yes, one does a biopsychosocial model. And because so many people and children with ADHD are put on medications, you need to know the pharmacology. You need to have, it would be helpful to have relationships with physicians that you can collaborate with. I often find myself in a position of actually doing quasi-medication management because I see the kids much more often than the physicians do. So I think if you're going to get into this work, you need to have some background in the pharmacology and be a little bit of a social engineer as well. I mean, sometimes the easiest way to reduce a problem that a person is having with ADD, a person with ADD is having, is to do a little manipulation at school or at work.
Oh, so social engineer means to change those environments.
Yeah, putting a kid in the front of the class. I mean, you think this was, and it's really not rocket science, because that puts the distractions behind him, and it's easier for the teacher to redirect a child by tapping on the desktop than from the back saying, Jason, look forward, Jason, where's this, Jason, where's that? And so, yeah, the social engineering.
Now, where do we get this knowledge? I mean, you mentioned the medical part, needing to know all of these different drugs, for example, and how long they last. Where can we find this information out? Well,
there are national parent groups. One's called CHADD, CHADD.org. You can go to the website. They have very good information, up-to-date information on their medication, because on their advisory board they have some physicians as well as psychologists. They're for professionals. You can't pick up a journal without almost seeing an article on ADHD. It's probably the best researched children's disorder of any of them. It's also the most common. It's the major reason why children enter the health delivery system, mental health delivery system, is for attentional problems.
So that would be like one specific set of skills or strategies that a psychologist would have to have, this whole notion of medication and medication management. Are there others?
Well, they would certainly have to understand how families relate together. They'd have to know some developmentally what children can.
Family systems, developmental.
Certainly basic kinds of learning theory and contingency management. And add a dash of creativity, because one of the things that we know with ADHD kids is the same reinforcer does not work over time. You have to set up menus of reinforcement, and parents have never thought about changing the reward system. And so a little bit of creativity will help.
Now, are there steps that you follow when you're working with someone with this problem?
Before I see a child, I send the family forms, history to fill out.
Okay.
I send them teacher rating scales to take to school and have them fill out. If they haven't had a physical exam in the last year, I do that just as a good idea to make sure there's nothing physically going on.
So all of this has gone on before you've ever met with them?
That's correct. And I require a complete copy of their school records. Sometimes schools have two different files on them, and they call them different things in different places, but one is the usual academic records, and the second place is where there's been specialized testing, and you have to get 2 releases to get those, not 1. So I get all of that before I see the child. So, and I want I should add school report cards if I can get them from the parents. Because you look at the department and you'll say, listens attentively, X, uses time wisely, X, stays seated, X. And so you pick up lots of things from the report cards as well. So I have a huge database that I start with. Okay,
so you gather this information, it sounds like, right away.
And I'll look at it the night before or the morning of, or sometime before, so I don't waste their time and my time flipping pages. I try to do this before. And I'll see initially the parents and the child together, and then I'll see the child alone, so I want to do some other kinds of rule-outs, some of which I've done with the parents, some I need with the child. I also use some computerized testing, some other rating scales when the parents get here, so I wind up with 6 or 7 databases.
Okay, so you got testing, you got child interview, parent interview, all these different records you
collect. School records, yeah.
And do you follow a process then, or do you used to say we gather a lot of information and hope the child moves,
Well, one of the things I put in probably 25 years ago was a swivel chair, which I'm going to market and sell for $1,500. And the child, you have the child sit there and take a look at your watch and see how long it takes before he starts to wiggle and shuffle. And it's amazing, and then you watch the parents, and they'll say, don't wiggle, Jason, don't. And once I see how the parents have handled it, then I tell them, I'm going to take over. Don't worry, I'll take the management function over. Because I then want to see how he'll respond to me, and to how well he'll comply with me versus the parents. So there's many ways to collect data in the course of the evaluation, and after I collect all of that, I get the testing, the computerized testing done, I've got the rating scale scored, the teacher stuff and all of this. Then I start seeing if I can or cannot build a case for ADHD, or am I having conduct problems, oppositional defiant disorder, do I have all 3, do I have learning disabilities?
So these are, maybe I don't have this right, but these are seldom just pure ADHD problems?
I think it depends on where your market is. I see, most of what I see are the pure ADHD with learning problems. I do not see in my practice what has been reported as the comorbidity with oppositional defiant and conduct disorder. I see almost none of that. I'd say 5%, but the reports are 35 to 50%. So that might just mean because I'm in an upper middle class market area, I'm not going to see that. Or other groups are more tolerant of the symptoms and don't come in for services. So I see almost a pure ADHD/LD problem.
But so a lot of what you need to do is to make a differential diagnosis here too.
Absolutely.
And try to
and those are the 2 most common: conduct disorder, oppositional defiant. Be careful of the childhood depression and childhood anxiety disorders. You have to look for those things that can mimic the attentional problems. And so it's a rule in, rule out process.
So once I get all of this data collected, does it affect the prognosis? Is there anything I could learn that would let me know whether or not this is going to be a good person to work with?
Well, the research shows the 3 major variables affecting prognosis. And the most important is a warm, empathic family. And of course, the family we saw today really was that. A warm, empathic family, the intelligence of the child, because the brighter the child is, the more you can do cognitive training, and socioeconomic standing. And that's relevant because with funds, you can afford to get the things the child might need. Tutors, specialized testing, so on. So those are the best predictors of outcome. On the downside, the more aggressive and the more hyperactive the child is, the less positive is the outcome.
So you're getting some idea about how successful your interventions can be.
Yes.
And you're going to try to work at making a warmer environment is one of the things that you're going to do.
The phrase that I use is making the world ADHD friendly, and however that has to happen, at school, at home, at Boy Scouts, and there's simple interventions. One little boy wanted to be a Boy Scout, but he had trouble with his energy level. So they let him be always part of the group that marches the flag in and marches the flag out, and that was just enough extra activity that he could discharge because he was off meds in the afternoon, worked fine. I mean, the interventions can be very, very small, but very, very effective.
So you collect this data, you make this diagnosis, then you make the world friendly. Is that kind of the steps you'd follow?
Yes, yes, and then you monitor.
You monitor.
And
yeah.
I often let the parents try it on their own if they look like supportive, enabling parents. Like, I also provide a lot of material, kind of bibliotherapy. There are books to read, websites.
So people learn they're not alone, that there's lots of...
Yeah, it's great to know I'm not the only one who has one of these kids, and there's times I want to strangle them. That's not so uncommon if you're an ADHD parent. And to learn about not all teachers make good ADHD teachers. Some of the rules they have with the state's Department of Education. So part of my job is to enable the parents to become their child's advocate, because nobody can do that better than they can.
Now, does it work, this kind of intervention? Is there research, that supports this kind of intervention with kids and their families?
The data is fairly clear that the cognitive behavioral interventions are really the treatment of choice for ADHD kids. It's not been demonstrated that long-term psychotherapy or psychodynamic therapy for ADHD is effective. It may be effective if there's co-finding anxiety, depression, but not for the ADHD.
Okay, so this is then the treatment of choice.
Most of the people that I know of who work in this field would say yes. There may be somebody who would say no, but the preponderance of the group would say yes.
So in a moment we're going to watch you work with Ethan and his mom. Can you set that up for our viewers, and what should they be looking for in this interview?
Looking at several things. Looking, of course, at the child, how he relates to his mother, how mother relates to the child, how he relates to me, the stranger, even how he relates in this kind of setting of a televised interview. See how much eye contact they have with me, with them. Can you hear that in what they say and what they do, that they've bonded? And also hear that they can disagree without becoming angry and upset. And then listen as the interview goes on, as I move from getting information to then trying to provide information. You're doing a good job. You're doing the right things. There are other things that we can try that I think will help. Why don't we try these things, try those things? So it's educational, supportive, and new interventions all going on at the same time.
So we were going to focus on them, but we're also going to focus on what you do, and that's getting some data, some education, making some specific interventions.
And getting them to laugh a little bit.
The laugh and the positive part.
And getting them to smile.
Let's watch.
Okay, thank you. Okay, Ethan, you have attentional problems, correct?
Yeah.
Yeah. How old are you?
13.
13. And what grade?
8th.
8th grade. You like 8th grade?
Yeah.
Yeah. Next year it's high school? Change schools?
No.
Stay in the same school?
No, wait, yeah, I'm changing school.
You're going to change school, okay. Mom, when was his ADD diagnosed?
About 2 years ago.
2 years ago. Have you been on meds?
Yeah, we tried Concerta, and then we tried off medicine. We tried natural remedies, and now he's on Adderall.
Adderall. How much does he take?
He takes the smallest milligrams just once a day in the morning.
Once a day. Ethan, can you tell when the medication kicks in?
Yeah.
Can you tell when it kicks out?
Yeah.
Yeah. Mom, can you tell the difference?
Yeah, it doesn't seem to last throughout the whole day, as opposed to what the pamphlet reads. It doesn't seem to last till he gets home. About midway through the day, like in school, it starts wearing off.
Is he taking the standard Adderall or the Adderall?
The XL, yeah.
Yeah, it's supposed to last 12, but often it doesn't.
Yeah.
Okay. What kinds of problems, Ethan, I'm interested from you as well, what kinds of things don't happen that you need or want to have happen?
Sometimes it helps me get my homework done, like it wears off like in the middle of the day, so I can't finish my homework.
So homework at home becomes a struggle?
Yeah.
It's an understatement.
Okay.
It's very difficult.
What kinds of things have you tried to get the homework done?
we have to do everything with complete quiet. We can't be cooking or eating. He has to be in a quiet spot with, none of his siblings can be around. In fact, nobody can even be like in the same room or he's distracted. Every little thing will distract him. No TV, no radio, no noise at all. And that seems to work to a certain extent, but it's like he shuts down because he feels like it's almost like his mind is moving so fast, he can't keep up with it.
Ethan, do you get frustrated when you're trying to do your homework?
Yes, a lot.
Do you find your mind wandering or just being distracted by other things?
Yeah.
Thinking about what I'm going to do later, tomorrow, what's on TV?
Yeah.
Yeah. Have you tried anything else to try to keep yourself focused?
No.
How long does homework take you?
2-3 hours per assignment.
Ouch, that's a long time. Per assignment?
Yeah.
Oh.
And we're not finishing the assignment. That's 2 to 3 hours, and we give up because we have to go to sleep.
Sleep, sure. When the medication wears off, are you at home or at school?
School.
School. So we need at home to find you a quiet place, which you have, but a way to figure out to get the homework done faster. How long can you work before you take a break?
If it's still working, I could work for a long time.
How about off the medication?
I can't work.
You can't work at all.
No, when he doesn't take it, basically he can have his homework in front of him and he has no idea where to begin. He gets so overwhelmed.
Could you work in 10-minute intervals? Could you work 10 minutes, get up, walk around?
No.
Could not even do 10?
Maybe. It depends what subject it is.
Yeah, I want you to be honest. If you don't think you can do it, then that's the answer.
It depends what subject it is.
What's your hardest subject?
That would be reading.
Reading. Tell me this, do you have trouble reading the words or remembering what you read?
Reading the words.
Reading the words. So you'll see the words, but your mind is thinking about something else. Is reading on grade level, do you know?
No.
How far below is it?
He's in 5th or 6th grade reading level.
Okay. So reading is a real issue for you. What's your easiest